We'd like to extend a warm welcome on behalf of the Public Health Foundation of India and the Indian Institute of Public Health, Hyderabad, on the occasion of our Foundation Day lecture and the 10th anniversary of the Indian Institute of Public Health, Hyderabad. Indeed, a proud privilege to be amongst this august gathering and to have luminaries of excellence in all fields and walks of life to be present with us this evening to share this occasion. I would like to take this opportunity to place on record my thanks to all of you who have made time on a working day to be here this evening. May I request the dignitaries to come onto the dais. Padma Vibhushan Palli Ramarao Garu, Chairman International Advancement Research for Powder Metallurgy and New Materials in India, and our Chair for the Advisory Council for the Indian Institute of Public Health, Hyderabad. Professor Ramarao Garu doesn't need an introduction. He's an Indian scientist noted for his contribution to the field of physical and mechanical metallurgy. Yes. I would then request Mr. C.K. Mishra, who's currently heading the Department of Health and Family Welfare, and this will be his first interaction after the new policy has been announced. Indeed, a privilege for us to be in Hyderabad, the first to hear him after the policy. Thank you, Mr. Mishra, for accepting our invitation. I now come to the next person who needs no introduction, and I will have a series of many that will happen such. Professor Srinath Reddy, President, Public Health Foundation of India, formerly the head of Department of Cardiology, appointed as the first Bernard Lown visiting professor of cardiovascular health. So, again, request to keep it very brief. Thank you. Our director at the Indian Institute of Public Health, Hyderabad, Professor G.V.S. Murthy, Vice President, South for Public Health Foundation of India, Director, IIPH Hyderabad, and Professor, London School of Hygiene and Tropical Medicine. I will not say more because I may be cut short. I will also like to request our esteemed panelists for this evening also to come up here so that we can engage in one activity straight after the other. Shri Rajeshwar Tiwari, Principal Secretary Health and Medical Family Welfare Department, Government of Telangana, a civil servant from the 1986 cadre and has several years. Nobody wants me to introduce them to the gathering. My privilege such. Dr. Karnakar Reddy. He's the present Vice Chancellor of the Kaloji Narayan Rao University of Health Sciences, Warangal. Okay, I'm not going to go beyond that. Dr. Prakasama, Executive Director for Academy of Nursing Studies, Women's Empowerment and Research Studies. Thank you so much. Dr. Somaraj Garu, again doesn't need any introduction to anybody in Hyderabad, and I think this part of the country. Dr. K. Varaprasad Reddy Garu, Padma Vibhushan, founder of Shanta Biotech and advisor to the Indian Institute of Hyderabad and advisor to RAS Life Sciences Private Limited. Privilege, sir. We have a lot of young, pretty girls as students who would want to come up and felicitate the panelists and the guests on the dais. Dr. Anusha, Professor Srinath Reddy, Dr. Durga, Dr. K. Krishna Kumari, Miss Udipana, Dr. Neha, walk out the other side, Dr. Prachi, Dr. Prachi, yes, to him, Dr. Prakasama, Miss Daisy, Dr. Tejaswini, and Miss Seher. I would now request the guests and dignitaries on the dais to go and invoke the blessings that we all need by lighting the lamp. Thank you very much. I now request Professor Srinath Reddy, President of our foundation, to please take on the further proceedings. Thank you.
Professor Palle Ramarao Garu, Mr. C.K. Mishra, other dignitaries on the dais, luminaries in the audience, ladies and gentlemen. As one who is neither young nor pretty nor a girl, it's my privilege to welcome you all on behalf of the Public Health Foundation of India to this event, which is a very proud day in the life of the Public Health Foundation. We completed 10 years of our life last year, but since we will be completing the 11th year next year, we are still now in the process of celebrating that event. But more importantly, the Memorandum of Understanding for starting the Indian Institute of Public Health in Hyderabad was signed in April 2007, and therefore this is the 10th year of the Indian Institute of Public Health Hyderabad, and therefore these two events have been combined together to have this Foundation Day event. We now have 5 Indian Institutes of Public Health, one in Gandhinagar, one in Delhi, Gurgaon, one in Bhubaneswar, one in Hyderabad, and one in Shillong. Hyderabad is poised to become possibly the de novo university which will affiliate other institutes. In fact, that is our fondest aspiration once the campus construction is completed. Though Gujarat has its permanent campus already completed and launched by the Chief Minister last October, we are looking to Hyderabad as the institute which will then host the entire PHFI family through a set of affiliations. Hyderabad is also unique in the terms of its having a very large ancillary center functioning out of Bangalore, where the government of Karnataka had very kindly allocated space for training a large number of government-sponsored candidates in their diploma in public health management. Hyderabad has now started its Masters in Public Health program to add to its on-campus and off-campus diploma programs, and also the MSc PhD in Health Informatics, which it runs in partnership with the Council of Science and Innovation Research. We also partner the Central University of Hyderabad in an MPH program. Indeed, today we have had an excellent workshop in big data analytics in partnership with the University College of London, which again suggests that in many areas of health which have been previously neglected in terms of academic training and research, now Hyderabad is beginning to make a major difference. But ultimately, the difference that we make will have to be seen in terms of improved population health indicators, and all of PHFI, especially the Indian Institutes of Public Health, are dedicated to working very strongly for health system transformation in partnership not only with their host states, but also in the regions where they are serving. We are working very closely with the Government of India, providing technical support in very many key areas, and we are also working with several states in providing technical support, especially in the southern region. In Kerala and Karnataka, we are supporting the governments in piloting universal health coverage programs in 2 districts each in each of those states. We have also been invited by several other states to provide them support in developing public health cadres. Indeed, with a new national health policy calling for establishment of public health cadres in every single state, and even the vision document of the Planning Commission of the Niti Aayog also asking for public health cadres to be established in at least 10 states within 3 years and in all states by 7 years, I believe now the road is open for having public health cadres with trained and well-skilled and socially motivated public health professionals. And that is where the Indian Institutes of Public Health will fill a major gap, and some of the initial mission for which PHFI was set up would progress. But we also see working in very many areas of health system strengthening and support through well-directed implementation research, which will give us valuable lessons on how innovations can transform the outreach and effectiveness of health services, also is an important area. Since public health deals predominantly with prevention and health promotion, but also with how health systems are organized for greater efficiency and equity, we believe all of health services research and health services strengthening comes under the ambit of public health, and that is how we believe our Indian Institutes of Public Health should function. So we now welcome this opportunity to have Mr. C.K. Mishra deliver the Foundation Day lecture. This again is a departure from past precedent. We have always had the lecture in Delhi. We have always had the lecture with a very eminent international public health expert who visiting us and delivering a lecture on a topic which we felt was of relevance to India. This time we have chosen Hyderabad as the venue because we believe that the spotlight now should be on Indian Institute of Public Health, Hyderabad. We did turn the spotlight on our Gandhinagar Institute during the launch of its permanent campus last October, but now it is very much Hyderabad's turn. And we also thought that because of the transformational directions that have been proposed by the National Health Policy, which was unveiled recently, the new National Health Policy of 2017. Who better than the architect of that policy, Mr. C.K. Mishra, to come and deliver the lecture? Even before this policy saw the public eye in print, we saw Mr. Mishra providing very effective leadership to the National Health Mission as Additional Secretary and Mission Director, National Health Mission. And then subsequently, as Secretary Health and Family Welfare, he has been steering the health systems in the country towards a greater dedication to public health goals and to bringing about much greater health equity. And that's why we have requested him to speak in this particular Foundation Day lecture on reducing health inequities in India, the role of the center and the states, particularly since in the recent years the responsibility has shifted to the states, but then the entire teaming up of center and states is absolutely vital for cohesive, coordinated delivery of health policy and health services. We are indeed privileged to have Mr. Mishra here with us today. I read from his CV. I will not read out the CV, but that he, apart from having done his graduate training in St. Stephen's College, also did a distance education diploma from Nalsar in Hyderabad. I asked him whether it was on campus or off campus, and he said it was off campus. I said, you did a great deal of disservice to Hyderabad by not coming here. Now you'll have to make up for it by stepping onto the land of Hyderabad, becoming an honorary Hyderabadi, and experiencing the warm hospitality of Hyderabad. I argued with him if the President of India can come to Hyderabad for summer, then so should he. So we have Mr. Mishra with us, and we look forward to his lecture, and we look forward to the interaction of the panel that we have assembled for a later discussion and responses to the lecture. We have a very distinguished panel. Again, I will not run through the introductions. I'll let them speak for themselves when the panel convenes. Thank you. We have a very short film on the Public Health Foundation of India. Subsequently, I'll request the chair, Dr. Ramarao Garu, to initiate the proceedings by inviting Mr. Mishra to deliver the lecture.
all of whom I offer my profound respects, ladies and gentlemen. It's a great honor to have been asked to make a few brief remarks on this PHFI Foundation Day. Let me first of all wish PHFI many happy returns of the day. The core concept of PHFI is embossed in the PHFI logo, which is translating knowledge generated into action for societal good. May this laudable concept continue to flourish for decades to come, and the good name of PHFI be etched in India's edifices to inspire its numerous denizens for generations to come. At the outset, I need to clarify, I'll be brief, let me assure you. I need to clarify my position. I accepted to chair PHFI Hyderabad Advisory Council, not because I felt I was competent to do so, but only because I could not say no to Professor Srinath. I admire him immensely. It's not often that we come across someone of such amazing professional caliber and who at the same time can plunge himself heart and soul into his chosen mission. PHI therefore is incredibly fortunate to be blessed with Professor Reddy's sterling, if I may add, noble leadership. PHFI is just about 10 years old. 1 decade is not a long time in the history of an organization, of the kind that Professor Srinath Reddy, Shri Rajat Gupta, and the eminent board of PHFI, given their far-sighted vision, have aimed at creating for the benefit of our country. One takes a few minutes to take a look at the multi-stranded growth of PHFI. One cannot but marvel at the fact that PHFI has grown tremendously, indeed incredibly, in the last 10 years. 5 centers was mentioned by Professor Srinath Reddy. 2 of them have started postgraduate diploma, master's and PhD programs in public health related topics. I mentioned the higher education programs because I believe that no motivating force is more powerful in driving an youngster in getting seriously absorbed in his chosen discipline than the programs that are designed to award him respected academic degrees. All said and done, it is securing these degrees that truly enhances an individual's professional substance. Research in India's many medical colleges is at a low ebb at the present time. Research is not for academic thrill. Let me quote Sir C.V. Raman, what he said about research. Research is civilization and determines the economic, social and political development of a nation. I must therefore applaud advanced research in public health related topics that the different centers of PHFI are pursuing in a way as to come up with a great number of impressive publications and thereby attract respected fellowships like those of Queen Elizabeth Diamond Jubilee Trust, Wellcome Trust and Infosys Foundation, just to name just a few of these. It felt great to hear from Professor Srinath Reddy yesterday and also today in the morning that PHFI publications, the citations of PHFI publications are comparable to those of celebrated Johns Hopkins University. We fervently hope that the research achievements of PHFI will bring about a transformation in India's research seen in the broad medical field. I can go on, but I have to cut down. We have a foundation lecture coming up. I do not wish to go on in this vein because the person who has worked almost 24/7 and traveled around the world to several countries, not to mention from one industry to another, is Professor Shri. He can tell us the decade-long riveting PHFI story more authentically. On behalf of all of those assembled here, I wish to sincerely and respectfully compliment Professor Reddy and his hard-working team on their phenomenal accomplishments. Just one more point. The Human Development Report has just been released by the United Nations Development Programme, UNDP. The report says that among 188 countries which have been ranked, India in 2016 has slipped down from rank 130 to rank 131 in Human Development Index, HDI. You are surely aware that one of the dimensions of HDI is long and healthy life of a given country's people. In this context, the national health policy announced by the government is a very timely national policy. The policy aims to, I quote, build on progress achieved so far to reach the goal of every citizen, to build on the progress achieved so far to reach the goal of every citizen living a healthy and productive life. Breathing life into this policy is required, says Professor Srinath Reddy in a signed article, and describes how. Implementation of any policy, particularly that related to health, of teeming millions of India is a daunting challenge. Conquering this challenge requires myriad initiatives by numerous people. One small example I wish to cite. I request you to permit me to cite. The Department of Science and Technology, Government of India set up the Technology Development Board to manage what was called Fund for Technology Development and Application. The initiative was facilitated by the 1986 R&D Act, via which a fair amount of money was annually collected for import of R&D, know-how, etc. Dr. Manmohan Singh, the then Prime Minister, helped DST to create this fund for commercialization of known or indigenously developed technologies. One of the notable beneficiaries of TDB loan fund was Dr. Prasad Reddy, who is the founder of Shanta Biotech, for producing on an industrial scale recombinant DNA vaccines. This famous product, hepatitis B vaccine, has been resoundingly successful, as against the then unbearable import cost of nearly rupees 800 per pediatric dose. Our public-spirited Dr. Reddy, who is here, sold Shanta Biotech vaccines at rupees 50 per pediatric dose. Shanta Biotech now is one of the world's largest manufacturer of H1B vaccine. Other companies followed suit and thereby hangs a tail. This fascinating story is worth telling at this time when the national health policy has been announced to illustrate the imperative need for novel initiatives for implementation of policy. PHFI is also cast in the mold of a novel initiative, which is in a sense ahead of the policy, as it has been operating in line with the objectives of national policy. To explain what is meant by novel initiatives, please allow me to quote Albert Einstein, who said the following: "The significant problems we face today cannot be solved at the same level of thinking we were at when we created them." I want to say something about the Gini coefficient. Public health directly imparts public welfare and therefore embodiment of public good, especially in the context of prevailing health inequalities in India. Wealth inequalities are measured by the Gini coefficient developed by an Italian statistician, Corrado Gini. If the Gini coefficient is more is the gap between the rich and the poor. I wonder if an analogous coefficient can be invented to measure health inequalities in India as well as other countries, so that we know where we stand among the Committee of Nations. Such a coefficient will also enable us to know how we are progressing from year to year. Let me then conclude by saying that for any program, public health not accepted, to capture the imagination of the public at large, it should be a top agenda item in every possible forum. Following that, it would be desirable for our political leaders to articulate their vision for public health, and for our distinguished senior government functionaries to frequently and publicly discuss the issues related to public health. It is in this context that all of us should feel reassured by the detailed article authored by our Honorable Union Minister for Health and Family Welfare, which appeared in the Hindu a few days ago. More such articles need to be written, and many more talks need to be delivered for ardent advocacy, work to be carried out, and thereby inspire philanthropic interest for meeting India's public needs. Thank you. I invite you, sir. I took a few minutes because he asked me to, so I apologize to you, but please come and deliver. Shri Mishra.
Thank you so much, Professor Rao. I wish you had carried on. I could have just come towards the end. Distinguished dignitaries on the dais, very eminent personalities here present in this hall, all those who follow public health closely as a critical tool to carrying on India's healthcare delivery, and present in this hall, I am extremely privileged to be here this evening before you to share my views on the topic that Professor Reddy has given me of inequities in the health sector and how center and state can resolve this. But to be very honest, I did mention to Professor Reddy that I was not the right person for this job, because even in this hall, the kind of wisdom that is there, I should really have been sitting here and learning rather than speaking. But permit me to share a few thoughts based on my 3 decade plus of public service and practical experience that I've had in the field. But first and foremost, congratulations PHFI, and on behalf of all of you, let me thank Professor Reddy for the extraordinary leadership to PHFI in all these years. We are proud of the institution, and this is indeed the ideal time to remember how deep the foundation of the institution is and how high it will grow in the years to come. I am extremely grateful for this opportunity to all of you, particularly so because we are going to talk about public health today. That is one critical element to the entire health system delivery in India. I dare not say has been neglected, but certainly sidestepped. It is time we brought public health into the main focus of our healthcare delivery system in the country if we really want to achieve what we have set out to achieve. And PHFI in particular has a stellar role, if I may say so, to play in actually carrying this exercise forward. Today, it plays a crucial role in the public health landscape of India and supports huge amount of national research network, transforms public health education in India, largely through its 4 institutions that are set up, and I really hope the fifth one comes up fast. And they have a range of collaboration with international organizations, national organizations, states, various ministries, which makes them a formidable force to reckon with when we talk about public health. I am neither an academician nor an expert. But a lot of things that we do in public health today, the inputs come from the foundation. So as government, we are extremely grateful to them and also depend a lot on them for their inputs. But if you look at the overall goal, this goal is something that has been shared globally and has its roots in the history of public health. And we go back to 1948, the United Nations General Assembly adopted the Universal Declaration on Human Rights, which declared in one of its articles, I think it was 25, where they said, and I quote, "Everyone has the right to a standard of living adequate for the health of himself and of his family, including food, clothing, housing and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, etc., and lack of livelihood in circumstances beyond his control." So this makes healthcare delivery very central and fundamental to the living existence and perhaps the right of a person in the country. And it is in this context that we are discussing this. But let us for a minute concentrate on the Indian healthcare scenario, if you permit me, before we come to the equity issues and other things. India has a unique healthcare scenario. We are among the few countries to whom the international community does not miss an opportunity at pointing out that you have the largest burden. Numerically, even if we do extremely well, we'll still continue to have the largest burden given our population. But unfortunately, in many of the aspects, even as a percentage of the total health disease burden that we have in the country, in many diseases, we do not come out extremely well, which is a cause of worry. If you look at the Indian healthcare scenario, it's a complex one, and one which is not there with majority of the countries in the world. We're still grappling with the basic issue of maternal and child health, which continues to be our focus even in the main national program, that is the National Health Mission. We thought that was complemented only by the communicable disease problem which we had in this country. Some of it which we've been successful in removing. But we are perhaps the only country as large a size of this. I'm leaving out some of the smaller countries which, we shouldn't be comparing ourselves with. But even in the neighborhood scenario, if you see, with a triple burden, because now we are threatened with the non-communicable diseases. If you look at the cause of death mortality picture in the last 10 to 12 years, there's been a complete shift. Today, 62% of the mortality is because of non-communicable diseases. It was just the other way around about 10 years back. So there's been a complete shift in the disease profile of this country. And to me, that just increases the complications for a healthcare delivery system that you design and implement. Because the design has to be dependent on the problem that you really identify. And this has been complicated further by issues of nutrition, issues of affordability. And, whenever you really want to do this, you look at the complete prevailing healthcare in the country. And one thing that strikes you is that even after all these years of effort, we've not been able to reach everyone. I'm not even talking of larger issues of quality, etc. Merely the access part of it. So, having the largest birth cohort in the world, for example, becomes incumbent upon us to actually focus ourselves there. And with the kind of limited resource and the manpower that you have, you are all the time juggling between one problem and the other. So what I'm trying to say is that this is a critical issue as far as India is concerned. And add to it the problem of out-of-pocket expenditure in India. The out-of-pocket expenditure in India, if you rank among the 89 countries that we rank, we are somewhere around 182, 103. 58 to 60% is a very high out-of-pocket expenditure. Therefore, this should bring us to a very critical issue of public provisioning. Insurance, which is the other aspect to cover the out-of-pocket expenditure, covers close to 25 to 30% of the sick population. That is the insurance cover. The actual outgo is not more than 10% in this country. So we have a critical element of public health provisioning which must form the basis for our plan. So there are two aspects to it. When you talk about resource, one is the public provisioning and the other is the private sector support. Public provisioning, even in a global comparison, has been low in India. The investment has been low. We are still at close to 1.2% of the GDP. I mean, even if there is an argument that in absolute terms it may not be so true because the GDP size is very large, even the per capita investment in health has not been very high. On the other hand, the private sector's contribution has not been uniform across the geography. There's very little support that you get from the private sector in the primary healthcare scenario. Private sector has done an extremely commendable job particularly in higher secondary and tertiary care. Unfortunately, in selected regions. So that geographical spread also we have not been able to exploit. So it's a unique thing. So in this scenario, when you are thinking of running a system where you want to infuse more and more investment of public health, as a country, one issue that we must debate is, where do our investments lie? Should they lie in healthcare or hospital care? And that is the central point that I want to make today, that the investments, whether we like it or not, have to be in healthcare as far as India is concerned. And that is why the entire movement to push, promote and put in place public health. The investments will have to be in primary healthcare, preventive and promotive healthcare. If public investment is adequate in this, I am confident that in the years to come, the gap filling will be done by the private sector. So we need to converge the resources of the two, and we need to create a system. I recently met one of the ambassadors of the Central European country, and while we were discussing the healthcare in that country, he very seriously told me, we are very proud of one thing. I said, what? He says, we are proud of the fact that our population to bed ratio in hospitals is lowest in the world. To be very honest to you, that is something we need to be proud about. So we need to create that population by making adequate investment in primary healthcare, preventive, promotive healthcare. So that is one part that we need to keep in mind. But on the other hand, even after all these worries and criticisms that India has not done X, India has not done Y, I think it's time we stood up and looked at what India has done. You look at your basic indicators. Look at IMR, look at MMR. Last 7 years, the reduction in MMR and under 5 mortality in India is much, much faster than the global average. We are at a point today when we have suddenly become lower than the global average as far as MMR is concerned. But the critical element is that this fall is not uniform across the country. That is why that critical element of inequity which we will discuss today. Several success stories have come in the country. polio was one. Last year we had the elimination of the neonatal and maternal tetanus. We had yours elimination. So a lot of things have been happening. Look at TB and malaria. Even though they are threats today, the mortality is almost over. I mean, we've almost managed to do that. And please appreciate that we've done that with low investment and acute shortages in the healthcare sector. Therefore, I very strongly feel that as a country, when we criticize ourselves, we must stand up and celebrate success as well. We must stand up and pat our frontline health workers on their back for what India has done. It's none of the policies that have got you there. It's their hard work and dedication which have got you there, each one working on behalf of 3 others because of the shortages. So we are on the right track. But yes, a huge amount of challenges ahead of us. Before I really come to the challenge, since Professor Reddy mentioned it, let us spend 2 minutes on the health policy of 2017. It is in this background of part success, some failures, that we brought out the 2017 National Health Policy. The last one was 2002. The disease profile, the epidemiology, the context, the investment, the growth of private sector, they've completely changed since then. Therefore, this new focus on the new health policy, which many of you would have seen. But since I can't go on and on with the health policy, let me just say that there are 3 things the health policy sets out to achieve as a large aim. 1, expand access. 2, lower costs, make it affordable. And 3, improve quality. So everything that you see in the health policy is built around these 3 basic pillars. As a major departure, for the first time, the health policy very strongly realizes the fact that health cannot and should not be the government's business alone. It factors in the huge potential that the private sector has to join hands with government to deliver what we really intend delivering. So, but at the same time, the policy talks about large amount of provisioning in public health and preventive promotive health. In fact, the policy says that 2/3 of the resources should ideally go to primary health care. I don't know how much of that will happen. The policy also for once says that we will raise our expenditure, public spend, to 2.5% of the GDP by 2025. Extremely ambitious. Because that means translating around 2 lakh crores that we spend between center and state today on public spend to almost 4 times plus by 2025, which will be a huge ask. But as a policy, unless we set out to do, at least spell out what we want to do, I don't think we'll get there. So this is a very ambitious policy, and policy centrally recognizes inequities and also provides solutions. This is the first time in the policy that we are talking about specific targets of elimination. We have talked about Kala-Azar being eliminated this year, leprosy by next year, filariasis this year, and so on and so forth, and a very ambitious target of TB by 2025. If we can do that, it will be a miracle. But that is what we have set out to do, and accordingly, the action plans are now being prepared. This brings me to an issue of investment, which we always keep talking about. One central thing that when we talk about public health we must remember is each one of us is worried about more money for health. I strongly believe that if not everyone, some of us should also be worried about more health for money. We must look at the kind of investments we are making and the kind of return on investment that we are getting. We have done well, but we have not got adequate returns because we still aren't organized enough in the public sector to provide the kind of focused quality of care that we should be. After all this investment today, if 60% of OPD is happening in the private sector, we need to gear up our public health institutions. And we need to ensure that with provisioning of free drugs and free diagnostics, more and more such people come to them. But my own take is, and this is based on the field experience I can share with you, no matter how much free provisioning you do, unless there is quality in healthcare delivery, people will not be coming to you. So that is the critical element that we need to keep in mind. So having said all this, we are aware of various challenges that the health sector throws to us. Disease burden is one I spoke about. Acute shortages of HR. And I think we'll have to live with some of them for about the next 10 years or so. We've done some very good work in the last 2 months to increase the number of seats both in the undergraduate and postgraduate medical education. Huge amount of reforms are coming even before we have the new bill. But that will translate into availability only after about 7 to 8 years. So that's a long distance to cover. How do we overcome this challenge? The medical fraternity needs to rethink and needs to come around on the table to take a question head on. And I address this to all the doctors present here with a request not to throw this idea right away. Give it a thought. Why do we need an MBBS qualified doctor in a sub-center or even in a small PSC? What is the kind of service we want to provide at that center? Why can't we have, like many other countries, a huge army of mid-level service providers who can handle those things? Let us not get into technicalities of whether that person can prescribe as per the medical council norm or not prescribe. Let us provide. And I think the government should only be a platform for provisioning. Something that must reach the people. So this is something that we need to. And then there is this huge problem of the unfinished agenda of MDGs. And here I must share my pain with you. All these years I've been telling all my officers in the states that MDG goal of under 5 mortality, which was 43, is a done deal. Last week we got the results from the Registrar General's office. The goal is 42 and the result is 43. I was very worried, so I found out, and he said 42 point something, so round it off to 43. So this time it's not the lack of hard work or progress, but statistics which has done us in. But I strongly believe that we've reached where we intended to. And this is why I say that we need to really, really congratulate all those who are in the field doing this. But perhaps the largest challenge that we face in the Indian healthcare provisioning is inequities in India. And if you really want to provide accessible, affordable and quality healthcare to everyone in this country, you cannot do it without addressing inequities. Professor Reddy has set out a topic saying inequities, and then he says center and state. I think it's a bit misleading, because these inequities will not be addressed only by center and state. There are a huge number of other stakeholders, including the private sector and others, who will have to step in if these inequities have to disappear. Let me, for a while, just discuss some of the inequities with you. You know, India, if you really see, is currently undergoing a number of socio-economic, demographic and epidemiological changes, as I said. And the challenge is very unique. And among all these continuing challenges, one of the most major challenges that we face today is the issue of equity. the Indian health system faces the ongoing challenge of responding to the needs of the most disadvantaged, underprivileged and unreached section of the society where we intend to reach. And this, unfortunately, is further aggravated by the fact that there is extremely high out-of-pocket expenditure. And you would be surprised to know that because of the high out-of-pocket expenditure, close to 8 crore families every year lapse into poverty line, which is a huge problem that we are facing. Therefore, equity is one of the key policies, key elements and principle of the national health policy. It has to be an affirmative action if you really want to reach those you intend to. It means minimizing disparity on account of gender, poverty, caste, and even geography. In the Indian context, that's very critical. It also implies greater investment in areas where these inequities exist. One of the principles that we follow, and that is a standard management practice, is incentivize those who are doing well and disincentivize those who are not doing too well. According to me, it does not work in healthcare delivery. Because if you disincentivize those who are not doing too well, and there is a huge amount of inequity, you're doing harm to nobody except the person you want to reach. You will never be able to, really get healthcare there. So the solution lies in, while we actually incentivize good performance, we need to have our spend, hand-holding and support doubled in areas which are not able to do so that we can get them onto that track. Healthcare delivery cannot be calculations of economics. We'll have to act differently in this. But if you look at the overall inequities in India, it's income, it's education, it's human development, and several other factors. And they are indicators of basically distributional differences in the health status of the population. The problem of inequity is that evidence shows that the poor, vulnerable and disadvantaged face also the greatest burden of disease in this country. And here, let me tell you that 8 states in this country account for 70% of the maternal deaths in the country. Just 8 states. So they are the one which have not done too well, huge amount of inequity there, but they account for the largest disease burden. Therefore, the argument is, do more there to get that down. Have specific area-based planning. Let me now just try and spell out some of the inequities that we see. Let us take, for example, the fact that only 47% of children of the lowest wealth quintile receive full immunization, while in the highest quintile, it is 80%. The rates of institutional delivery has increased. Every state talks about 90%. But if you look at the NFHS data, there's a difference of 35% between the poor and the rich. You look at the scheduled caste population immunization figures, there's a difference of close to 20% between those who belong to the scheduled caste, scheduled tribes and those who don't. Let us look at, for a while, all this with a gender lens. And this is NSSO figures that I'm quoting. There's a huge difference between men and women. And let's take some states. States like Goa, Gujarat, Madhya Pradesh, Tamil Nadu and West Bengal. There is negligible difference between the men and women who did not seek treatment despite medical advice, which means choice. Whereas in states like Mizoram, Bihar, Orissa, Jammu Kashmir, Uttarakhand, Nagaland, the percentage is 2 times of men and women who did not seek health care despite medical advice to do so. So that is the kind of geographical inequity that we are talking about. Now, even other outcomes, for instance, IMR is 25 for urban areas, while it is 41 for rural areas. All our investments till date is in the rural areas. Please remember that. Even then, the difference has not come down substantially. Similarly, you've under 5 mortality, 34 in urban and 56 in rural areas, against an all India norm, now 43. So, this requires overcoming several factors that actually challenge equity in service delivery and equity in health financing and financial risk protection. Who is it available to? This also brings me to another point. What are the states spending? Look at the wide variation that the states have in the spend. Expenditure on health in, let's say, states like Kerala and Tamil Nadu are 3 times more per capita than Bihar, which has the lowest spending at 93. Post NHM, all these states picked up their expenditure. Bihar doubled it. It's at 182 today, still the lowest. So what I am trying to say is that despite efforts and newer programs, these inequities have continued to be there. And there are significant differences if you look at what Madhya Pradesh is doing. Let us take IMR. Let us take Kerala and UP and compare it. Therefore, the question that I am posing to you is, where should investments lie? Or where should larger chunks of investment of public spend lie? And particularly when physical access is still a major barrier to both preventive and curative. Look at the number of beds in India. Look at what it is in the urban sector and look at what it is in the rural sector. There's no comparison. So equity matrix really needs to be integrated into all health system policy and implementation strategies. I would just like to quote Thailand's example. Thailand's experience of building capacity for equity monitoring and strengthening partnership between data collection bodies and its Ministry of Health is a new experiment they have done very successfully. And it's time, even in the Indian scenario, we started monitoring equity. If that is our focus, we need to look at the growth, the difference every time. So, when we are talking about inequities and we say that we actually face this problem, now what do we do? There's a lot that has been done. First and foremost, center and state need to act in tandem if we really want to pick this up. Then there has to be a pitch in from the civil society, the private sector, the NGOs and whoever are in the field. What did we do to address this in the recent past? To quickly tell you that we came up with a concept of high priority districts in the country. We identified 184 districts in the country which were in the lowest strata of implementation and tried to push resources, manpower and a better managerial capacity to actually execute. I am happy to report that in a recent analysis we are now going to change the 184 because many of them have got out of that. This, according to me, is a pointer to the fact that what we thought of as greater investment in this area has paid dividend. So we should continue to do this. Mission Indradhanush, for example, which is one of the most successful programs that we launched recently. We picked up 247 districts which we thought were the problem districts. India was growing in its full immunization coverage at a rate of 1% per year for the last 11 years. Last 2 years, when we introduced Mission Indradhanush, the growth every year now is 6.5%. That's phenomenal. That is because you addressed the problem where it was. So that is why I say equity in healthcare delivery is very, very critical. Tribal areas, for example, although it's not uniformly across the state, but we've asked the state governments, all limits of hiring in terms of paying money to contractual doctors are over as far as tribal areas are concerned. In fact, the word I used to use with all my officers is, pay what it takes to get someone to that area. Unless we do that, we will not have. And Chhattisgarh is a recent example, Professor Reddy was also mentioning, which has done it. So it's doable. And we just need to concentrate on primary comprehensive health care. You know, these 8 states account for 60% of the population of the country. We broke it down further. It is 162 districts which are creating this program. So now we have launched a new program called Parivar Vikas for 162 districts, where we will try and reach family planning services with other services combined, so that it's a comprehensive program we can run in these districts. We've done the same thing for leprosy, for example. Everybody said leprosy has been eliminated in India because at a national level we have done it. Look at the sub-national level, you've still not done it. So the point is that our program and policies, the planning processes must change to focus on areas where services have not been available so far. And the equity story is not just about persons, people and population, it is also about geographies and provisioning. So we need to get that right, and once we have that, we need to just recognize the inequities, address them and invest. If we can do these 3 things slowly, but the whole thing is very complex. It's not an easy thing. But honestly, it's not so complex that we really can't break this. I think it's doable, and let us together, we need to work with institutions like PHFI and all of you who are so keen on public health provisioning in India. Let us work together to evolve a system to address these inequities, and in geographies, in populations and groups, if we are able to push this, none of the indicators in the country would really be such that we say that we can't even compare to our neighbors. If you want to get out of this, the critical factor is, let us push investment and energy of all the people put together. And one thing that we must remember is, it will not happen unless there is a common platform for everybody to work towards national objective. And I do feel that it is the incumbent upon government to create that platform. We'll certainly be able to create that platform, invite all of you to join us on that platform to resolve these issues and try and see that we are able to reach everywhere, everyone in every corner of this country. Thank you very much, ladies and gentlemen.
With the chair's permission, may I now turn the attention to the panel after thanking Mr. C.K. Mishra for the very scintillating lecture in which he has highlighted not only India's public health and health challenges, but also the successes, and laid out the pathway for utilizing the opportunities that await us by bringing multiple stakeholders together across the country to address not only the aggregate national indicators in terms of the gaps with global goals, but also the inequities that lie in disaggregated analysis between different geographies, social groups, and ensure that these inequities are bridged through collective societal response. We now move to the panel discussion, in which we would be requesting each of the panelists to provide a response to some of the questions that I will pose to them, keeping in mind Mr. Mishra's overview presentation. Mr. Rajesh Tiwari, as the Health Secretary of the Telangana State, and particularly listening to Mr. Mishra expound the national health policy, but also set the context for the center and the states increasing their investment, but also bringing together multiple stakeholders together on a common platform. How do you feel the states are responding to the new scenario of greater responsibility for resourcing, design and delivery of health services, while keeping in mind the national health policy and India's commitment to achievement of the SDG targets? From this?
Good evening, ladies and gentlemen. Very nice to be here today and listening to the experts on the public health policy. The question given to me is basically, because most of the things have been covered by our secretary, I will just focus on certain questions that have been raised. One of the major constraints to effective functioning of the health systems is the shortage of trained health professionals in many categories. How do you think we can overcome this, especially in the delivery of primary health services? I accept this statement. Telangana is one of the states in our country, has got very good health system in place, about 3.6 crores of population, having about more than 5,000 sub-centers throughout the state, about 700 primary health centers, and 100 plus secondary institutions, and 6 medical colleges, and in tertiary institutions about 20. But when you come to the grassroots levels, we have overall health department about 20,000 posts that have been sanctioned by the government, and obviously the majority posts are the technical ground level positions, and keeping them together, keeping them updated, keeping them trained is a real challenge. We have state level institutions, Indian Institute of Health and Family Welfare at the Hyderabad level, and we have also erstwhile 10 districts of Telangana. We have the district level institutions also to keep on updating the basic, the professionals join with the basic qualifications in the field, but they quickly get outdated unless they update themselves in day-to-day functioning and then policy changes that occur in the sector. It's very difficult to carry forward the objectives that we set. Now, the major challenge remains recruitment first, getting the trained manpower, qualified manpower, and then the placements is the really major challenge for the governments. The most meritorious wants to be in Hyderabad, but the services that our secretary also mentioned, the inequities, if I analyze Telangana, probably our inequities lies in the northern 3-4 districts, Adilabad, the Warangal and Khammam, but the most of the trained professional would like to place them in Hyderabad and around. That's one of the big challenges we face. And the attrition rates that remain in the interior areas is very high. So it's one of the big challenges, and certainly the solution lies in really having a kind of cooperation with the private sector. I was discussing with the Dr. Somraju just few minutes before, and he has suggested that certain areas, particularly we must involve the private sector to train our manpower and cooperate with them. Apart from the government institutions that are there with us, we would like to open up, training needs, the updation and knowledge transfer from private sector to the government manpower. This could be one of the solutions. Thank you very much.
Dr. Prakasama Garu, one of the statements made by the speaker today, Mr. C.K. Mishra, is that doctors must now give up on this outdated model of doctor-centric healthcare provision, especially for primary healthcare services. Obviously, nurses, allied health professionals, and a large number of community health workers can play a very active role in delivering these services. How do you think we are actually geared up to meet the shortage of healthcare professionals, which is across the board? We are seeing shortages even among nurses. We are seeing shortages among allied health professionals. So how do you think we are geared up, and how can we actually respond to this challenge by providing a larger number but also more skilled and socially motivated health workforce?
Thank you, Dr. Srinath Reddy Garu. And also I will say, when Mr. Mishra mentioned this, he mentioned it very hesitantly, because he said right in the beginning, he's posing this to the medical community, that there has to be a rethinking in public. I think this I'm so sorry. No, I don't have it with me. I don't have it. Okay, let's hope it's better now. But it's very important, because this national health policy has been in incubation for quite some time. Mr. Mishra, you know, that 2015, and then a lot of discussion, and finally it is now out. And there are especially very good points there. And though he didn't mention it and didn't focus on that a lot, he just said that the medical community has to rethink or think of where we need to focus our energies. The public health cadre, which the policy is talking about, and hopefully it will be introduced, and we were discussing this earlier with Dr. Srinath Reddy, this has to become a reality. If we look at public health, we cannot really look at reducing inequities without reducing inequities in service provision and in service providers. We need to think of what is the cadre, what is the quality, what is the type of providers we need at the ground level. Though he has mentioned that the public provisioning is the most important for primary health care, and 2/3 of the money is going to be now hopefully channeled into primary health care, which is what we need, which will take a long time. However, what does that translate into in terms of human resources? What is the type of provider we need at the ground level? Though as diseases progress and as illnesses progress in a human body, you need a specifically skilled super specialist at one level, but at the primary health care level, what we need is a broad-based provider, a provider who knows a little of everything, so that at the, he was mentioning about the bed population ratio. We in India, instead of looking at how many beds we have, we need to look at how many beds we can avoid, how many hospital beds we can avoid, how much hospital stay we can reduce. And for that, we need a cadre of providers who are broad-based, providers who are not doctors alone. Public health is not medicine alone. A little bit of medicine, but he himself mentioned that is promotive and preventive. If we have promotive and preventive, we do not need so much of expenditure on tertiary care. If we can reduce, and 3 of the points that he mentioned of the health policy, increasing or expanding access, reducing cost, and promoting quality. The first 2 are to be done at the ground level. So we need to look at this cadre of providers at the ground level who will be technically trained, but who will be in the spirit of activism, in the spirit of public health activism. Reducing IMR and MMR cannot be equated with reducing inequities. That is one level of reduction. That is something we can handle when you reduce IMR, MMR, but that doesn't really mean we have reduced inequities in healthcare, inequities in healthcare provision, inequities in healthcare providers. The broad-based healthcare providers we need in the country are not at present trained, tuned, or have the aptitude to make inequities less. Take the ASHA or the A&M, the lowermost cadres in health. They are not empowered enough to look at inequities. They themselves are suffering with inequity. How can they promote equity? Therefore, the way you train them, the way you tune them in their thinking, that is what is required. I think this is what the central government and the state governments need to think. The number of providers we need at the ground level should be massive. We need many, many more. Health is not immunization or injections or IFA alone. It is education. It is a lot of it is talking on one-to-one level. It is a lot of convincing. It is a lot of counseling and guiding. And if it is a multi-dimensional social determinants which are determining health and leading to non-health, the debt burden will be much more if we don't reduce those inequities. Those inequities can be reduced only if you have this broad-based provider at the ground level who need not be a doctor. Dr. Srinath Reddy, I'm so happy that we raised this issue. Why do we need a doctor at sub-center or PHC? For 50 years, we are harping on this issue of having a doctor, pushing this young person, young girl or boy, to go and force them to work there in the PHC, but we know they are not going to be there. Why don't we think alternately? Why don't we think in a more practical manner? And this is my appeal to both the state government, Telangana represented here, and to the center, to take up this issue of having broad-based healthcare providers from technical fields, from a broad field like nursing, from non-health fields. I was amazed that the PHFI has governing council members who are not all doctors. I think this is what we need. We need health to go into a broader field than medicine alone. Thank you.
Thank you, Dr. Prakasham Garu. I can assure you that the initial disturbance was not hostile interference from the Indian Medical Association or the Medical Council of India, but in any case, we have taken care of the problem. Now, Dr. Karunakar Reddy Garu, public health calls for multidisciplinary learning. Now, the Kaloji State Health University, the University of Health Sciences in Telangana, has now enabled us to start an MPH program. However, there are also medical colleges who are charged with developing public health competencies, but they have fallen short in terms of their curriculum and competencies in building up that kind of professional expertise. How do you think we can actually engage the medical colleges much better in advancing them to become better contributors to public health capacity building?
Thank you, sir. Good evening, everybody. It's a very initial part of establishment. We have started our university hardly 6 months back. And to be frank, there is very little research or public health work that's going on in the medical colleges at present. See, what we have is the Department of Social and Preventive Medicine giving some amount of training to the medical students and having some PHCs attached to it. But as far as research is concerned, it requires a lot of infrastructure, financing. So, for the past 1 decade, Ministry of Health, Government of India and MCI has taken the initiative. So there's a lot of uniform infrastructure across all the medical colleges at present. I was thinking for the last 6 months that when we give our thesis to the students or when we allot PhD topics, it should be more public health oriented, where we'll aim to decrease the indicators like MMR, infant mortality rate and all. And I was thinking maybe I am outdated in my thinking. But after listening to the Secretary of Ministry of Health, Government of India, I think it is contemporary to have such topics given to the students so that there is no shortage of material in our country, so that whatever research they are able to do will go a long way in improving the society's health in general. And coming to Public Health Federation of India, last time also when we met, Public Health Federation has offered to assist the university in the research modality, in planning the curriculum, so that will take care of society health and our rural health needs. So probably we'll have more meetings and include in our curriculum public health at all levels, not just undergraduate level, even at postgraduate level, the public health issues and how surgery or medicine or gynecology will have an impact on improving the rural health of our Telangana state. Thank you. And one more point I was thinking was, we have to encourage research in Indian system of medicine. What I have seen in last year when I attended NTR UHS convocation, most of the PhD courses research is done in Indian system and then non-medical subjects. Our postgraduates from clinical subjects are hardly taking up any PhDs, and most of the PhDs and fellowships are offered by corporates. So last time about 6 months back I was discussing with Gurnath also how is going to help us in formulating the research programs and all, which will have an impact on public health. Thank you.
Dr. Somaraj Garu, you represent the best face of private sector. Unfortunately, that's a mixed picture in rest of the private sector, but clearly it's a societal resource that needs to be optimally utilized, as Mr. Mishra said. So, how is the private sector responding to India's health challenges, and what do you see as the future of public-private partnerships in the health sector?
Thank you, Dr. Srinath. Actually, if I knew the answer to it, I would be practicing in my village, not sitting amongst all of you. But anyway, now that we are where we are, and we said the face of private sector doesn't look that good to the public, and I was talking to Mrs. Sangeeta Reddy. She was talking about the problems we have in private organizations. I won't bother you with all that now, except telling you that on the question of nurses doing the services that you are talking about, or physician extenders, we call them, advanced nursing practice, and also physician assistants and whatnot. There was already worldwide experience available where, say, nurses in Uganda, they were trained to do deliveries as well as hysterectomies. And the results, when they compared with what was happening when doctors were doing, were far better with nurses than doctors. Nobody is clapping. So then, so in other words, we don't have to reinvent the wheel. It's already happening in the rest of the world. The why that systems failed is lack of persistence on the part of the organizations that were helping these things to happen. That perseverance was needed actually. Then coming on to what private sector can do, I would say, last night you were addressing this issue. I won't be repetitive except telling you the care we give when a patient walks into our hospital systems is that should be safe, effective, efficient, timely, patient-centered and equitable, and also we should add sustainable. So we are talking about equity today, and somebody else already pointed out, we want to equity to the community around. We have to address the inequities inside our medical organizations and healthcare systems. The star doctors in our hospitals, particularly private, even public hospitals, they are paid how many times more than the lowest category employee or a nurse who is continuously with the patient. The doctor comes only for 5 minutes, morning or evening. And then what are we doing about that? If you didn't address that inequity, Dr. Prakasham already pointed out, so it's not enough to just reduce the cost of stent or cost of a drug. That's very easy. Anyone could do it. But then can you do this? Can you address this? And only government can do it. You should address, willing to take some pains to get into the models that we are delivering both in private and public and correct these inequities inside the organizations first, and then everything else will be taken care of. Because they require to be paid well, they require a social standing and recognition, then they will perform. And then they will go anywhere you want. So, but be willing to pay them as much as you would have paid your doctors or even more. So then the other issue that comes is when you say money is not an issue, sorry sir, I don't agree with you, because money is an issue. If you spend in one place, you can't spend somewhere else. And the models of healthcare like Arogyasri, etc. are oxymorons. Then nobody is willing to talk about it. So then to do something about these things. You are wasting away all your money for something like angioplasties, bypass surgeries, and this transplantation, that transplantation, and completely neglecting primary care. And then, so in other words, the corrections require not only from public sector, but also from private sector, but also public sector. Let us correct ourselves. Then secondly, coming to public sector and private sector, what we can do? Say, when I say you have to be all that, right from prevention, primary care, secondary care, across the spectrum of delivery, and say public health foundation type of organizations look at the communities, and we look at individuals. Last night I was talking about they look at the forest and we look at the trees. Both are important. You can't take away the trees and the forest is not there. So failure of these institutions to come together and work, and working in silos, is another reason why right things are not happening. And it is here that we have to bring the best brains, like many of you sitting here and there, to come together and see whether we can redesign our healthcare delivery models, which is suitable for our situations and countries. And also, I don't agree that doctors should not be in public health foundation bodies, etc. I don't say doctors alone. The healthcare system delivery model, if I ask, is there a single nurse sitting here in the whole conference here? Oh, great. Yeah, sir, your name is written as doctor. Sorry, I said. So then, good. I am glad you are there. So more and more of that should happen. Nurses should be in the hospital boards, and rest of the healthcare model should be widened now. So then something will happen. When I say public-private partnership, when say healthcare, the government has, it's not that there is not money, there is not enough money, it's not that there is no infrastructure, etc. Government has enormous infrastructure, buildings, land and everything, and enough money, and a lot of people can pay. And how we can bring together all this is how that infrastructure translates into delivery system is human resource. That component was neglected all these years, thinking that there's a lot of effort and thinking went into improving the delivery system and the process of care, but neglected on educating ourselves inside the system. When I say system, it's not just doctors and nurses alone. Whole delivery model has to be improved. And say again, doctors, I feel, are healthcare system people, doctors, nurses, whatnot. Some of these people should be in members of the rule-making bodies of the organization, legislative councils, member of parliaments, etc., where I feel somebody like Srinath Reddy should be sitting in parliament, like Dr. G.N. Rao. Dr. G.N. Rao sitting there, should be sitting in parliament. So some of these issues will be easier because without political will, nothing great can be achieved. Thank you very much, sir.
I do not expect to be a member of parliament, but I do swear that I shall not use my chappals in the aircraft. Dr. Varaprasad Reddy Garu, the Indian pharmaceutical sector has contributed immensely to the availability of drugs and vaccines. What more can they do to improve the affordability of available medicines, which still seem to be a little high priced in the Indian context? And more importantly, how can we increase the access to new medicines where the international market is commanding the prices?
Namaste. Normally I should say I am very happy to be here, but I am embarrassed to be here between so many great thinkers. I am not a thinker, but whatever is given to me I have done. Sir, you asked me a question that the present pharma products are costly, how to bring them down. I think I had to narrate 1992 or 93 story where the vaccine, at least one vaccine, hepatitis B, was sold in the country by importing at 780 rupees per dose. WHO given a mandate that every newborn child should be vaccinated and that should be included in the immunization schedule. Many countries did that, but maybe around 70 countries could not do that, including India. But other countries are very small countries. They are economically, educationally, sociologically, culturally backward. But India also could not do. The reason is it's not available locally. If it is available in small quantities and at very high cost, only rich and people with affluence could do that vaccine to their children. So, an initiative was taken by Shanta. With the recombinant DNA technology, the general apprehension in the society is it is highly technical, scientific, and India is not ready for biotech products. Because I approached many pharma industry giants, why not to take up this hepatitis B? WHO warned India also to include this into immunization schedule by 1997. I am talking about 92, 93. All these people had the same answer. India is not ready for biotech products, and no biotech company was existing. Okay, some beer making companies were there. They were brewing beer. They were not saying at that time biotech industry. Now they are saying, everybody is talking that we are biotech, we are biotech. Even a barber shop is saying that I am biotech because he is using not soap, some other thing. So at that juncture, a fool like me, without knowing any technology or in science, I am an engineer, I am not a life sciences student. With sheer foolishness or blindness, I jumped into that. Our scientists did marvelous job. By 1997, we developed our own first recombinant DNA technology-based vaccine. A great achievement because only 2 countries or 3 countries knew this technology, recombinant DNA technology. But when our scientists did it at affordable cost, Shanta mantra is make it available locally in local currency and also make it affordable. Against 780 rupees of imported cost, we had to spend foreign exchange. In 92, 93, our foreign exchange results were very limited, hardly 300 million, just enough for 2 months imports. We have done it Indian rupees 50 against 780 rupees of imported cost. So, there is a sense of necessity in the minds of Indian entrepreneurs, and they have done their job. In the spirit of hepatitis B, many vaccines and many healthcare products we launched, around 14 products for the period of last 25 years of our existence. But my question here, with all due apologies to Mishra Saab, 97 this was given to the market at 50 rupees. Until 2011, It was not taken into immediate schedule by Indian government. 14 years. Our neighboring countries like Pakistan, Bangladesh, Sri Lanka, Nepal, they were buying from us, they were saving their children because it's very affordable cost. Our government has not moved forward. Why any other entrepreneur will venture to do this kind of work? But despite government, biotech revolution has come. Many people have come in. In addition to Shanta, there are many companies. In Hyderabad itself, there are 4 vaccine manufacturers. In the same spirit, we did many products. But today, what we launched at 50 rupees in 97, our vaccine is costing just 15 rupees. My point, sir, you are asking me how to further reduce and also asking for new products. Where is the margin for R&D? At 15 rupees, today water bottle, rather bottled water I call it. In open market they sell at 20 rupees. What is the research in that? What is the extra precaution they take? And in the same water bottle, in airport they sell at 60 rupees, in a star hotel at 150 rupees. And you put price control also over and above that. And a fellow who invests money into R&D and he develops a product after so much of regulatory clearances, each product will come out from mind to lab, lab to factory, factory to market. It takes 7-8 years. And that product, when it is sold at 15 rupees, Bill Gates, when he was here around 10 years back, at the time we were selling at 25 rupees. He asked me, can you make it at 10 rupees? Sir, if you can give your word or Office 70 or whatever it is, their software, at $1, I can give it 1 rupee. He doesn't reduce. He says, I need that money to donate. I also want to donate. Why should not make profit? Profit is not sin. At 15 rupees, if you feel that it is high cost, sir, for 2.5 hours of so-called entertainment, people are spending 200 rupees to see their heroes. Can we not spend 15 rupees for a life-saving drug? Sustainability is very, very important. At one time, Mishra Saab, tetanus vaccine was not available in the market. Government of India felt very sad about it. They were putting a lot of pressure on every vaccine manufacturer because it was sold at one time 18 rupees, gone down to 6, 4. They were asked at 3. Nobody produced. They stopped production. So if you overdo that in the name of reducing the prices, people stop producing. It is a very delicate balance between what is affordable, what is not affordable. And since 92, 93, our prices have come down every product. Already it was low when we launched. Important point is every input has gone up. At the time power tariff was 2 rupees 30 paisa. Now it is 11 rupees. Water is being sold at very high price. Human cost has gone up. We have third pay commission, fourth pay commission, fifth pay commission, seventh pay commission. When government is increasing salaries, naturally private sector also they have to increase. Every input has gone up. Our product price is coming down. Still, if you feel that pharma industry is not doing good job, I'm sorry, sir. Namaste.
Well, that was a heartfelt and very passionate advocacy for protecting the pharma sector, which is doing a great deal of public good. Perhaps a pooled public procurement system in which the government actually procures a large amount of medicines by eliminating multiple layers of middlemen will actually reduce the price without hitting the producer. And that's what many countries are now doing, and perhaps that could be the way forward. I'd like to thank all the panelists for their interventions, which have been extremely stimulating, and I'm sure the discussion will continue forward. Since the Health Secretary has to leave very shortly, we'll go ahead with the next part of the program.
I missed out one important information. In 93, of course, no bank will give for R&D. At least Ministry of Science and Technology, they were supporting some R&D activity. but their corpus was 150 crores. For all sectors put together. It could be textiles, it could be electronics, it could be cement, whatever it is. In that, we get a small portion. And even now, they increased it to approximately 3,000 crores. But not enough. One company in pharma sector in USA, Pfizer, their annual budget for R&D is $4.7 billion. National Science Foundation in America, they spend $27 billion every year. Where is our investment in R&D? How can we have any new products, sir? Very difficult.
What a fabulous evening, and we've had such interesting discussion that we've had over the last hour and a half. It's time to say thank you to all those who have been here and who have given us valuable advice and told us so many areas that we can actually collaborate and work with in the healthcare sector and more so in public health. I'd like to say thank you to Shri C.K. Mishra. Request Professor Reddy to give away tokens of appreciation to all those similarly to Mr. Dr. Karnakar Reddy. Professor Palle Ramarao Garu. Shri Rajeshwar Reddy, Shri Rajeshwar Tiwari, Srimati Prakasham Garu, Dr. Prakasham Garu, Dr. Somaraj Garu, and Dr. Varaprasad Reddy Garu. I'd like to invite Professor G.V.S. Reddy, G.V.S. Murthy Garu to give the vote of thanks.
So that just proves that if you work too long with Dr. Srinath, everybody becomes so-and-so Reddy. Whether it's a promotion, sir, I think. Thank you very much for that. It's actually a very auspicious moment for us for two reasons. If you look at people on the dais, you can have the who's who of the Padma Awards, right from the Padma Shri to the Padma Vibhushan. They're all there on this dais. And if I look into the audience, there are another 5 Padma awardees sitting in the audience. So what could be a better confluence to discuss our health priorities and public health concerns rather than have such a great confluence of intellectuals gathered here. The second auspicious occasion for us, in addition to what Professor Srinath had mentioned about this being the first time that the Foundation Day is being held outside of Delhi, the Public Health Foundation of India's Foundation Day, and the first time that we've had an Indian luminary talking to us, and you could just imagine what a great treat it was. Sumptuous treat that Professor Mishra today gave us. Thank you so much for that. Many of you may not know, he actually is in the middle of the Parliament session, and it's really a tribute of his interest in public health that he's come here to Hyderabad to be here with us. And the same thing with Tiwari ji, that right in the middle of the legislative session, they're able to spend time with us. So we have to really thank the government for initiating a public-private discourse on the Public Health Foundation Day, PHFI Foundation Day. But the other important auspicious thing that I was talking about is today is the eve of the Telugu New Year. Both the Telugu states, Maharashtra, Gujarat, we all celebrate our New Year, and you are here on the eve of the New Year.
And our New Year is very unique. We serve a dish, a chutney, which has all tastes put together. You have neem, you have mango, you have jaggery, and sugar cane all put together with banana. So it is giving you the sweet, the sour, the bitter, all put together on the New Year day, the journey which all of us have been through in this country in relation to public health. The ups and downs, but at the end of the day, the taste is always sweet. So thank you very much for being here with us on the eve of our New Year's Day. And thanks to everybody for having gathered here. Sir, I'd also like to mention, it's not just this group sitting here. We have our entire faculty staff at the 4 other institutes of public health and the Public Health Foundation of India who are listening in into the live feed that has been provided. Lastly, for that luminous group here, and even when the lights went off at the back, you could see the intensity of the people on the dais, starting from Dr. Somaraju Garu, Prakashamma Garu. Prakashamma Garu, obviously luminous, so it brings light. And then Varaprasad Reddy Garu, who always hesitates to talk, but when he talks, he just adds layers and layers of intellectual thinking and sometimes gives you nightmares. You may not be able to sleep that night. Dr. Karnakar Reddy Garu, who has been a major source of support. We would not have been able to do what we've been doing in Hyderabad without his support. Finally, the Doyen Palle Ramarao Garu, who has such a charming style of motivating us with his smile and humility that we're able to do what we are. We are thankful for him to be the chair of our advisory council in Hyderabad. Thank you very much and wish you all a happy Ugadi.